Good morning. Hi, everyone. Happy Friday. Thanks so much for coming this morning. My name is Tseng. I'm a pharmacist at the Immunodeficiency Clinic, Toronto General Hospital, and associate professor at the Faculty of Pharmacy, University of Toronto. And it's my absolute pleasure and honor to be the moderator for this morning's symposium on HIV and mental health. And I can't tell you how excited I was when the idea for this symposium came about, because I think we all recognize that mental health is such an important piece of someone's world and has such a far-reaching impact on every aspect of someone's healthcare journey. So before we get started, I just wanted to start with a land acknowledgement. CAHR, we acknowledge that here we are on the original lands, many groups on the national homeland of the Red River Métis, and we respect the treaties that were made on these territories, acknowledging the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration, gratitude, and humility. So thank you. Now, I have the great pleasure of introducing our panel speakers. I'm going to try and keep it brief, because otherwise we'll be here for the whole session just reading through everyone's bios. So Dr. Alexander Wong will start us off. He's an infectious diseases addiction and addiction medicine physician and clinician researcher with the Saskatchewan Health Authority. He's an associate professor in the Department of Medicine at the University of Saskatchewan. His primary clinical and research interests focus on HIV and viral hepatitis, particularly in marginalized populations, including persons with substance use disorder, persons who use and inject drugs, and persons in carceral settings. In these settings, he practices a full-scope addiction medicine, including opioid agonist therapy, harm reduction, and overdose prevention. He was awarded the 2021 CAHR for Excellence in HIV Research Award for Clinical Sciences, and in his administrative role, he works to expand system capacity and improve the care of persons living with substance use disorder and sexually transmitted and bloodborne infections across Saskatchewan. It was also Alex's birthday yesterday, so thank you. Should I introduce everybody else?
Do you want to introduce her?
Yeah. Let me go through all the intros, and then we can just keep flowing. Dr. Adriana Carvalhal is an associate professor at the Department of Psychiatry, the Temerity Faculty of Medicine, University of Toronto, and a staff psychiatrist at Sunnybrook Health Sciences Centre. She completed her medical and psychiatric training in Brazil, where she also completed her master's and PhD. She did further research training at the University of Toronto with a postdoctoral research fellowship at St. Michael's Hospital. She has a special interest in psychiatric disorders in people with HIV, and an interest in service delivery to marginalized populations. I've known Adriana for a couple of decades. She also has the best shoe collection you will ever come across. And finally, Dr. David Brennan is a professor with the Factor in Wentash Faculty of Social Work, University of Toronto. He's a registered social worker in Ontario and a recent OHT and Endgame Leadership Chair. He's the founding director of the Cruise Lab, which is an interdisciplinary, community-based social work research lab focused on health and well-being among 2S LGBTQIA+ populations, with an emphasis on HIV, STBBIs, social connections, community engagement, and mental health. And he has received numerous awards for his work and loves spending as much time and effort as possible watching films, theaters, and anything queer, and he is an unabashedly obsessed fan of heated rivalry. So I think a lot of us have that in common with them. So with that, I will get us started with Alex.
Good morning, everybody. It's a pleasure to be with you. Thank you for getting up early. It's never easy. It's an honor and a pleasure to be presenting with such a superb panel. I want to thank Merck, the panel, and the conference organizers for giving me the opportunity to speak today. So I'm going to just begin again by acknowledging that we are on Treaty 1 territory. There is a disproportionate burden of HIV, especially amongst Indigenous persons in prairie provinces in Canada. This cannot be separated from a legacy of colonization, intergenerational trauma, and systemic inequities. We pay our respect to our First Nations ancestors of this place and reaffirm our relationship with one another. Recognizing this history is important to our future and ongoing efforts to close very real gaps in health outcomes between Indigenous and non-Indigenous peoples. So I'm going to begin just with a bit of a high-level overview of some of the realities in our day-to-day practice in southern Saskatchewan. I work in Regina, which is the tertiary sort of referral site for our province, not far away. We're going to begin by talking a bit about how mental health influences every step of the HIV journey, from diagnosis all the way through to long-term well-being. Talk about some of the most common mental health-related challenges that persons living with HIV face, as well as the impact on the care cascade. Talk just very briefly about just some of the acknowledged comorbidities potentially from a neuropsychiatric perspective with some of the commonly used antiretroviral therapy that we use today. Finally, talk a little bit about some practical tools that we can utilize to integrate mental health screening into our day-to-day care of persons living with HIV, as well as some frameworks for engaging with other disciplines, including psychiatry and our various interdisciplinary teams. So I just wanted to begin just by highlighting, and many of you involved in the care of persons living with HIV day to day will be intimately familiar with how mental health related challenges affect every component of this care cascade, from accessing testing all the way through to thinking about long-term well-being, even beyond when someone has become virologically suppressed. So, if someone has tremendous stigma or previous trauma in the context of the system or the healthcare experiences and so forth, or whether there's shame and other components, that can often lead to challenges with regards to engaging in testing, and ultimately the diagnosis in and of itself obviously carries tremendous stigma, even in 2026, as well as considerable shame. This can obviously lead to difficulties with all aspects of engagement and linkage to care, and subsequently can play a significant role with regards to suboptimal adherence, or just people being able to manage and take their antiretroviral therapy in a way that leads ultimately to the end goal, clinically at least, of virologic suppression for HIV management. Even beyond this, HIV plays a role with regards to impacting the long-term well-being of persons in the context of mental health-related challenges, as well as substance use. And we'll talk a bit more about that in the next few minutes. So just some very high-level sort of slides. Mental health-related challenges and diagnoses are extremely common in persons living with HIV. This is not like Saskatchewan-specific data. This is just kind of general data for all persons living with HIV. Close to 40% of persons living with HIV have concurrent challenges with depression. Close to 30% will have anxiety-related challenges, and the rates of PTSD and trauma-related concerns are far higher in persons living with HIV compared to that of the general population, even more so in persons of female gender. There is obviously a much higher prevalence of either past or ongoing substance use disorder in persons who are at risk, as well as persons who are diagnosed with HIV. This can lead to a variety of challenges and consequences, as we talked about, with regards to the clinical care, including not feeling as confident, or just not being able to access, or not wanting to access, or being scared to access testing and diagnostics, challenges with regards to linkage to care, adherence, as we've talked about, which then can lead to suboptimal clinical outcomes as well, and ultimately significant mortality. This is just to highlight some of the most common challenges I think we all see, but kind of from the lens of kind of the day-to-day work that myself and the team in our ID clinic in Regina see on a day-to-day basis. We probably serve around 700 persons living with HIV. So thinking about depression, extremely common, and concurrent depression leads to challenges with regards to inertia, or just not being able to kind of get up and go and get things done, hopelessness, and persons with active depression and HIV are far more likely to miss doses of antiretroviral therapy and not be optimally suppressed. So screening for, identifying, and ultimately treating depression, as well as other mental health pieces, both with pharmacologic therapy as well as non-pharmacologic interventions, can play a major role. And I think it goes without saying that many of these components are also driven by the environmental factors and pieces around. So when we think about the challenges that many of our persons at risk and persons living with HIV face, we're thinking constantly about all of the various pieces around housing insecurity, food insecurity, income insecurity, and relationship insecurity that are exceedingly prevalent, and working with our clients to help manage these as best as we can. Anxiety and PTSD are also very, very common and can create a number of different challenges as well. Pharmacologic and non-pharmacologic interventions, including counseling and CBT, can be very beneficial. I have a particular bias towards substance use disorder because the prevalence of concurrent substance use disorder in our populations in southern Saskatchewan is extremely significant. Probably 60 or 70% of our overall cohort either have ongoing active substance use disorder or a past history of, and again, opioid use disorder, stimulant use disorder are extremely common. And one of the pieces that we've used to adapt is co-locating, the ability to provide these types of care and supports for persons right at our site. And then I'm thinking a lot more about ADHD as well, partly because I happen to have multiple children who have been diagnosed with ADHD. And as an old school Asian, I never really had this concept that ADHD was even a thing. I always was kind of thought that maybe it had something to do more with effort or just work or these things, and I understand now that that's not the case. And I'm reading the literature and understanding that there are much higher rates of undiagnosed and underrecognized kind of ADHD in many persons who use stimulants, which is exceedingly common in our population as well. So one of the things on the to-do list in the next year or two for me is to learn how to manage ADHD in adults to try to help co-locate and support these persons. Substance use disorder is, a piece that drives a lot of the work that we do day to day, particularly opioid use disorder. And I don't have time to go into all the details with regards to what, we try and do in our clinic, but it all comes down to having a client-centered, collaborative harm reduction approach where the goals of care are really driven collaboratively by the discussions that we have with, the persons that we provide care for. Sometimes it can be crisis related if someone's just had an overdose, for example. Sometimes it can be related to just reducing access to the toxic supply. And we try and provide all manner of services in-house so that we have the ability to provide, acute care for persons who present to our setting in significant opioid withdrawal. So we have a very high proportion of persons in our cohort with concurrent substance use as well as a past history of injection drug use. And as I said, very high proportion of persons with past or ongoing substance use as well as smoking as well. We all know that stimulant use is very common. The most common stimulant used in sort of communities across the country is crystal methamphetamine and various forms thereof. And so again, as I talked about, we think now constantly more and more about ADHD and self-screens and trying to access supports for persons who may have undiagnosed or unrecognized ADHD, as well as supporting non-pharmacologic measures as well for persons with stimulant use disorder, including access to treatment services, recovery beds, and so forth. So we think about all of these factors every day when we see clients in our clinic. I won't lie, like I rely personally very much on our well-trained and superb interdisciplinary teams, especially our nursing teams, as well as our pharmacist and social worker, to help support, the ability to actually recognize these kinds of concurrent comorbidities in our clients. Our usual model is that an interdisciplinary assessment for most clients will usually occur like at each visit. Sometimes if they're just coming in for OAT-related sort of concerns and so forth, that might be a slightly more abbreviated one, but in general, we try and provide a comprehensive review, and nursing and social work and pharmacy will often help administer some screening tools to identify whether or not someone has underlying depression, anxiety, and clearly delineate what type and how much kind of substance use is actually occurring, so that we can try and come up with a bit of a clinical plan for clients. Some of the other things that we see that I haven't really talked about include complex PTSD, trauma-related challenges, as we've talked about already, as well as just recurring grief and bereavement from, sort of repetitive trauma, the loss of close friends, loved ones, and so forth, are extremely common. So we think a lot about pharmacotherapy, and I'm not really an expert when it comes to using pharmacotherapy for, kind of things like depression and anxiety. We have started, our pharmacist, Jackie, probably plays a much more important role in terms of helping to support and start first-line therapies for depression and anxiety compared to myself. But we also try and acknowledge and provide supports for all the non-pharmacologic interventions that can be beneficial, not just in terms of the direct mental health related pieces, but obviously many of the other pieces around insecurities, whether that be income, food, relationship, housing, and so forth. Everything in the clinic is done from a trauma-informed and culturally appropriate lens. Again, I've been able to see the light over the last several years and have a more intimate understanding and appreciation of how important that is in terms of our day-to-day work, as well as helping to lead that by example. I am pushing the button as hard as I can. It is not going. There we go. Very quickly, antiretroviral therapy can sometimes cause neuropsychiatric side effects and adverse events. These, I would say, are generally not very common, but they definitely can happen. Back in the good old days, I started training in 2008. I remember the very first patient I saw as a brand new ID fellow in the University of Alberta Hospital was a person who had been newly diagnosed with HIV. And I read the guidelines. I was so stressed. I didn't know what I was going to do and what the different options were. And ultimately, we started that person on a tripla. Many of us who are of a certain vintage will understand and appreciate a tripla. But for persons with less experience, a tripla is well known because it was the first single tablet co-formulated, one pill once a day regimen. And it was efavirenz, which is an NNRTI, co-formulated with tenofovir and emtricitabine, which is similar to 3TC. And it was great, but efavirenz had a very high prevalence of neuropsychiatric side effects, things like vivid dreams, problems with sleep, depression, and so on and so forth. So there were oftentimes situations where persons would have to switch off this single tablet regimen and pick something else. So we've come very far in the antiretroviral therapy space. Dolutegravir has been recognized to have a higher proportion of neuropsychiatric AEs relative to the newer integrases like bictegravir and cabotegravir. I do kind of wonder in my mind whether or not some of this may have been related to co-formulation with other sort of older NRTIs like abacavir, for example, but it's definitely something to think about. Bictegravir and cabotegravir are newer integrases that you're all familiar with that are less associated with neuropsychiatric AEs, And then finally, there is something referred to as HIV-associated neurocognitive disorder, or HAND. There's varying degrees, and this is kind of inherent kind of neurocognitive sort of challenges ranging from sort of mild to moderate to severe that can manifest in persons living with HIV. Thankfully, this is far less common now than many years ago as a result of effective antiretroviral therapy. So just really quickly here, I'm going over time, just some practical tools that we can use. These are well-recognized screening tools like the PHQ-9, the GAD-7 for depression and anxiety, as well as the ASRS, which is like a self-administered sort of questionnaire that people can use to help sort of identify whether or not they are at greater risk of having ADHD, for example. And then different tools that we utilize as well to identify persons with alcohol and substance use disorder. So just a few things in terms of our experience overall. Like, we think constantly about this at every client visit. We have a bias towards substance use specifically because oftentimes persons with substance use disorder, particularly opioid use disorder, that often drives a lot of the clinical challenges and dilemma and prioritization for clients just with regards to the challenges with trying to avoid and manage withdrawal. And so that often becomes like a primary focus for us when we have a person with concurrent opioid use disorder, but we don't ignore all of the other pieces like depression and anxiety. We try as much as we can with varying degrees of success to provide, all services on site, including primary care, women's health, various care for substance use alongside the HIV care, alongside the wraparound supports that we talked about for persons living with HIV. And this all comes from a trauma-informed lens and a culturally responsive and appropriate approach. So those are just kind of my key takeaways here. Mental health is something that we need to integrate every moment of every day into the care of persons living with HIV. We talked a little bit about some of the antiretroviral therapy. I like to kind of remind people about depression as a significant modifier, and oftentimes managing the depression will help to, improve components of just that person's day-to-day life, including ART adherence and ultimately virologic suppression. I've talked a bit about some screening tools, as well as thinking about ADHD in persons with longstanding stimulant use disorder, and I'm looking forward to hearing more from my colleagues about some of their practical approaches. Thank you.
Okay, so good morning, everyone. So thank you for the opportunity to be here, and thanks, Alex, to really set the tone for the conversation today. So what I would like to talk is really to make a case about how mental health has to be seen as a core component of any HIV care. Not some things as we address when it's really severe or some things, but really as a part of the everyone HIV treatment. So in people living with HIV, common mental health conditions, as Alex mentioned, like depression and anxiety and substance use disorders are highly prevalent and highly impactful. They affect how people experience their diagnosis, how they engage with the service, and very concretely, where they achieve virus suppression or they get a good long-term health. So the way I'm structuring my 15 minutes here is about three questions. Why the burden of mental health conditions is so high in people living with HIV? How these conditions affect the HIV outcome along the care continuum, Alex mentioned this previously, and what means for the equity point of view, how we design service. So my hope you leave here seeing mental health not as some things add on, but as part of a basic and a good HIV care. So when we look at the high prevalence of mental health symptoms in people living with HIV, it's tempting for us to think, maybe it's part of the background condition But when we break down, it actually makes sense. First, we can see from the biological point of view, HIV, and there is a chronic inflammation, we know about this, and how this can affect the central nervous system. Alex mentioned this as well. And there is an evidence of the neuroinflammation can causing some of the neurocognitive symptoms. And even people on treatment, maybe this can contribute and can be perceived, and the symptoms we see in the patients can be more related with anxiety and depression. Second, there are clinical burden. We know it's an illness with a lot of stigma. It's a chronic illness. Often patients go to different phases, high viral load, maybe some opportunistic symptoms, some treatment side effects, then there is some change in the treatment. All of this combine, even the fact patients often have other medical comorbidities, they take multiple medications, all of this can work as a very big burden and in somehow affect how people can cope over time. Third, there is the psychosocial aspects. So receive a diagnosis of HIV can be experienced by the patients as a very traumatic experience, specifically if they are from communities where there is a strong stigma and discrimination. Many people have a pre-existing history of depression, anxiety, and trauma, or even substance use. So all this works as this ongoing stigma discrimination in itself can explain why people would have such a high prevalence of the conditions. So if we think high rates of depression, anxiety, and substance in our clinics, it's not surprising. Again, the burden is understandable, it's a multifactorial. Which means when we respond, the response has to be beyond a single cause or even a single, beyond a single intervention. So let's look a little bit more around depression. And I think the data here is very compelling. So what this slide shows here is really summarized findings from a large cohort study in the US, where they look for over 6,000 adults receiving HIV care in multiple clinics. So what they did, they followed the patients over time, and they assess multiple times measures of depression. So what the researchers, they create was what they call the chronicity of depression. So basically, it's how depressed the people were over time during the follow-up visits in this clinic. So, and then they look for three very concrete outcomes: appointment attendance, detectable viral load, and mortality. So, very interesting. So people who had a chronic depression, they miss more appointments. So even before we talk about viral load, depression already affects the basic thing like showing up to the clinic. So as the depression over time, as I mentioned, they assessed the depression in multiple points. As the depression became even more chronic, the probability of the patient to have detectable viral load was higher. So this is consistent with many other studies where they found depression, lower adherence, and the patients have a higher risk for treatment failure. So finally, what they found in this study was the depression was associated with a high mortality during the follow-ups. So for me, this is striking because it's linked mental health condition to a survivor in a very direct way. So depression is not just a comorbidity sitting aside, it's connected to retention in care, virological outcome, and mortality. So once we see depression, it became hard, and when we think about this data, it's hard for me to justify a model of HIV care where mental health is addressed only through ad hoc referrals. So, and then when we look for substance use, then the landscape is even more important. Firstly, as Alex mentioned, in some communities, this is probably one of the most common conditions in people living in HIV. And a proportion of these patients have harmful alcohol use and other substance, and often the undiagnosed substance use disorder. And I want to make a difference here. There is a difference between a substance use and a substance use disorder. And we can come back later to talk what's the difference between the two. Regardless, we know this can really impact outcome and lower quality of life. So let's look alcohol alone. So there is several layers where alcohol use can impact. So biologically, we know alcohol is associated with the liver disease, specifically in patients who also are co-infected by HCV. So can contribute to cardiovascular disease and even increase the risk for some cancers. And of course can interfere in adherence because affect the patient's routine, affect sleep, and often decision-making as well. So, and then if we look for opioids, I think the stakes are even higher here. So we know opioid use disorder is associated with poor engagement in HIV care. So patients are more likely to miss visits, they have a less continuity of care, and of course, the additional risk of overdose death, particularly in settings where we have a toxic drug supply and the patients have a limited access to harm reduction and treatment. So consistently, the literature has been shown substance use disorder, if they're left unaddressed, they have, patients have low possibilities to linkage to care, retention, and viral load, and I think Alex mentioned this as well. When treatment, harm reduction are integrated in an HIV care, we see those outcomes improve. So again, addressing substance in HIV, for me, should not be something we do when it's really severe, but should be, again, incorporated in any HIV clinic. So now I want to, did it pass? No. Alex, I have the same problem. Okay. So,
push hard.
Push hard. Okay. So what I want to do this in this slide here is really kind of take a zoom out and talk about a little bit about mental health in HIV and how this is interact across the life course. So we know many of our patients, they came with a history of early life adversity. So including abuse, neglect, loss, chronic instability. We know from large population studies that those experiences are associated with depression, anxiety, and substance use. And some of the psychosocial problems people experience when they are adult. So those conditions start in a very early life experience patients had. So, and those vulnerabilities start such early age, so they are translated in late exposures and risks the patients can take. So we know in individuals who had early life adversities, they are more to be in relationships who are violence is part. We know ongoing trauma became an issue as well, and they have a more harmful pattern of substance use. So imagine when HIV enters the picture, the same factors can shape how people perceive risk. So for example, unprotected sex, transactional sex, injection practice, and then after the diagnosis, all this is going to shape how the patients are going to interact with our health system. So again, all this together reduce motivation and energy to attend appointments. It's much harder to remember and prioritize medications. And of course, we're going to see amplified stigma-related stress, leading to avoidance to the service. So by the time someone starts to don't show up in the clinic, and often that's the moment we start to think if there is some problem there, and the patients are not taking consistent the medication, or they are struggle to achieve viral suppression. So actually we are seeing that's the point of the tip of the iceberg. It's a long chain of events led for so many years for those patients to be in that point. So the key message here is again, mental health should not be sitting outside the HIV care continuum, and we see how this runs through testing, linkage, retention, adherence, and long-term engagement in care. So I also want to locate here and talk a little bit about and look at these things from the equity lens. We know globally we are off track to meeting all those targets, 95, 95, 95. And earlier we were talking, I remember, 10, 15 years ago, thinking, who are the ones left behind? And we clearly know those are those patients who are socially marginalized and criminalized. So including people who use drugs, sex workers, transgender and gender diverse people, or those who are incarcerated, or they are living in an unstable housing. And we look what link all this. Those are the mental health we see leading all those disparities. So if we look from the individual level, serious mental illness and severe depression can create day-to-day instability. People may struggle with housing, income, food security, or safety, and make it very difficult to prioritize medical appointments and take medications every day. If we look from the social structural levels, HIV-related stigma, racism, homophobia, transphobia, and criminalization of drug use and sex work all create ongoing stress and create barriers to care. Homelessness and incarceration repeatedly, we know, has been causing interruption in continuity of care and medication access. And then if we look from the health system level, we may have clinics are not designed for integrated care, where mental health and substance use are carved in separate service with a long waiting list, poor coordination. Maybe providers don't feel capable and trained to support those mental health directly issues. And often, patients end up going to be under-recognized and under-treated those conditions. So all these layers, in practice, what often means is the people with the greatest mental health needs are the ones left to navigate a very fragmented healthcare system through different pathways, and again, they are going to not receive the care they need. So for me, addressing mental health is not only about improving individual outcomes, it's also an equity intervention. One can help narrow the gaps between the viral suppression and survival in between the populations. So I would like to end here, coming back to the core message of my talk, where we see mental health conditions and substance use disorder as very common in people living with HIV, in that they have clear measurable impacts on appointment attendance, adherence, viral suppression, and mortality. We also have seen these issues interact with the structural barriers in ways increase inequities, particularly for marginalized and criminalized groups. What follows is we cannot achieve actionable HIV outcome if mental health is not treated or is seen as an optional extra. It has to be integrated in how we design service. Whatever is through a co-located mental health health support, if it's a deliver brief interventions in the HIV clinic, maybe it's a collaborative care models, or at least a strong referral pathways that actually work. It's not the one the patient comes back a few months later, say, I never got a call from the hospital, the other hospital the patient had to go. So I'm not going to go here in specific models today, and if you check the WHO, UNAIDS, they have been providing a very clear guidance and examples how we integrate mental health in HIV service. And they show this is how improve access, retention in care, and overall health. So my invitation here for everyone is for us to think about our own setting. So how we are identifying depression and substance use in our HIV clinics? How easy is for the patients to get a meaningful support? And what would look like if mental health were truly treated as part of the HIV routine care? So thank you so much, and I'm looking for the discussion here with my colleagues and your questions. If it doesn't move the paper here. The paper sticks to the...
It's okay, there's a little pause, so we're good. Just checking those are the right ones. Okay. Good morning, everybody. How we doing? Caffeinated? Yeah, I am too. I am really, really thrilled to be here, to have the opportunity to talk a little bit about kind of what happens like outside of the clinic. It's actually really aligned with what my colleagues have said, and it's really an opportunity to kind of think through a couple of important ideas around social determinants, and actually kind of want to focus a little bit on community solutions, because I think my colleagues have covered clinical solutions, but I want to have the opportunity to talk more about some community stuff. So my conflict of interest disclosure. Okay, I'm not going to read everything on every slide, especially this one, because we've kind of just talked about it. But just to, these mental health symptoms and diagnoses, such as depression, anxiety, and PTSD, very prominent among people living with HIV. The impact on art and treatment and engagement in HIV care is well documented. Social conditions, including incarceration, marginalization, economics, shape the mental health outcomes. And I'm a social worker, so I'm going to just keep saying social worker. So if you're not a social worker, you can become one if you want. Talk to me. But I do mean it broadly, but I'm going to give a good shout out for my people. This is just a little bit of an image of what I'm going to, about what I'm going to cover today. So, as you will see in the center is HIV-related stigma, because HIV-related stigma is very highly associated with all kinds of mental health outcomes, and not just mental health outcomes, but for the purpose of today's talk, absolutely. The other social determinants of health, like housing and food insecurity, violence and trauma, employment barriers, and of course racism, which has a profound impact on a number of communities, but we are very clearly seeing in terms of our Indigenous and our Black Canadians that the impact is really quite overwhelming. So the remnants of the lovely project of colonization, he says sarcastically. just in case that wasn't clear. Stigma as a structural barrier. So it is, as Adriana has mentioned, that it's so highly related to depression, to PTSD. Women with higher stigma scores report more unmet mental health needs. And 1 in 5 people living with HIV have been denied health services due to HIV stigma. So you go to get the care you think you need, and there is such an experience of stigma and discrimination that you don't get that care, whether that's because of a choice you make or the way the system is structured, which is more likely. It's highly problematic. And of course, there's lots of places where mental health services do not exist, or they don't exist in a way that is able to respond quickly to people's needs as they come up. So in terms of the other areas in the diagram I originally did, housing instability is critical. We all know no one can afford housing in many parts of Canada. I live in Toronto, God help me, and I'm like a full professor, like I'm a very privileged person. I don't understand how we don't have better plans in place regarding housing instability. No one has completely solved that yet. And I can't wait till they win like a Nobel Award, whoever can get us there. But people experiencing housing insecurity, it impacts their mental health and their HIV care, as well as food insecurity. So the University of Toronto, for instance, these are students, young folks, had, I think, 2 food banks in 2018, and it now has something like 35 across the campus. That's not because people are bored and they're like, let's start a food bank. It's a need. And it impacts people's mental health because it adds to the level of stigma of going to a food bank or feeling like you need that. The way capitalism works is kind of your fault. Neo-colonial, neoliberal thinking often leaves it that way. So these impact people's stigma. It's stigmatizing to go to a food bank, period. And it impacts depression as well, as you can see here. So for many clients, the crisis is rent and food first, HIV and mood second. I've got to get housing for my children, and I've got to get food. Violence and trauma, violence-informed kind of practice has been a big buzzword for a while. It certainly has been in social work. But people who are dealing with PTS symptoms are also having more difficult time accessing mental health care, which sounds ridiculous. If you're me, that sounds ridiculous. That people who are experiencing PTSD are having a harder time accessing mental health care. That's not a sentence that should exist. Violence experience, and particularly among women. Sorry, I want to make note of O'Brien's work. Violence experiences are linked to higher levels of not having your mental health needs met. Gender-based violence, of course, is consistently higher with HIV stigma over time. And trauma-informed, culturally safe care is what I would refer to, or my colleague O'Brien would refer to, is it's essential, it's not optional. So what works? Well, I'm just going to say first and foremost, the system for providing mental health care is not going to be on this slide. Okay? It's not going to answer what works. Because we all know the structural ways in which the system, the structural barriers to accessing care are extraordinary and very complicated. But there are some evidence-based approaches like cognitive behavioral therapy that has been shown to shift adherence and depressive symptoms. Mindfulness-based interventions, there has been some really great research kind of coming down the pike, and even more since 2019, about moderate reductions in anxiety and PTSD. And that trauma-informed practice, which is a core framework for all who have experienced trauma, and let me just suggest that probably everyone in this room has experienced trauma. That doesn't mean you have PTSD, but all of us have had trauma occur in our lives. And so trauma-informed care is particularly important in relationship to mental health service delivery. And, you know, of course, queer, racialized, Black and Indigenous folks, people living with disabilities, women, and survivors of violence. So these work best when they're embedded in social and community support. So this is why the title is kind of beyond the clinic walls, because the clinic is critical and important, but there also needs to be other resources beyond the clinic walls. So a couple of, hit that, got it, hit it extra hard button. I don't know, it must be like slide number, whatever number it is, 9. So we know that peer support is one of the strongest evidence-based interventions. And I know many of you are peer support volunteers, program coordinators. I see quite a few out there, which is great. But you can see from here that a meta-analysis of 20 plus trials with 7,600 participants, you can see that there is a constant improvement in retention and care, in ART adherence, and viral suppression, and reductions in depressive symptoms. So this is the heart of social work to me. It is relational, it's strengths-based, and it's grounded in that lived experience. So if I have that experience and you have that experience, there's something that we have that hopefully we can support each other. I just want to name, I'm not going to go into detail because I don't have time, but if folks from these programs want to share information, but there are some unbelievably amazing programs here in Canada, and if you don't know them or know about them, this is not an exhaustive list. We'll be here for a while if we did that. But there are some extraordinary programs, and so I encourage you to look at these programs and other programs that might be more local or connected to you. So Casey House has this very interesting structured support program where people with lived experience it's integrated right into the care. It's into the care team. There's a peer support person on your care team if you are being provided care there. 9 Circles. Woo, 9 Circles in the house. Yes, yes. Hi. I have never been to 9 Circles, and I adore and love 9 Circles from Toronto. The work that you all do is quite is quite innovative and exciting. And, integrating indigenous, traditional, and Western medical and social work. Rusty, if you're in the room, I'm, making sure that's there. Addressing mental health, housing, and income, so those social determinants together. It's not, it is an integrated, holistic model. Fantastic. Two-Spirited People of the First Nations in Toronto has an indigenous land-based HIV care that combines cultural appropriate supports with care. And then I'll also just mention Positive Living BC, which also has a peer navigation and advocacy program. The Black Coalition for AIDS Prevention, Black Cap, and Women's Health and Women's Hands in Toronto have women's specific peer support programs for Black women. Amazing. And there's some really fantastic folks here this morning who are doing that. And of course, there are a number of national networks. So I will just say social work in action to me means that it's related to what my colleagues have said, which is it has to be part of your assessment. And in clinical care, you can't just take the temperature and the vitals. There should be consistent screening for housing, food, income, violence, alongside mental health. So if you're going to give the PH9 or PHQ9, you should also be asking about income and housing. Connecting community linkages, peers help people to know what is going on. That's not necessarily broadcast in clinical care. Of course, advocacy for income, housing, and benefits, and thinking about anti-oppressive practice in the sense of recognizing the impacts of racism, colonialism, and violence. And I don't think, I've been training and teaching in this area for years. I don't have enough training. So I think there's still more that we can do. I want to just mention system-level challenges, because as a social worker, I have to think on another level as well. The gaps that are in mental health care. For instance, that psychotherapy isn't covered, and for uninsured or precariously employed folks is an issue. Fragmentation between HIV care, mental health services, and social supports, and as well as the persistent intersecting stigmas that create barriers to counseling and care. So, what to do? Quickly, there's evidence. Use the evidence to invest, for instance, in peer-led programming. If you're working with an organization or in a clinic and you're not connected to a peer-led program, you're not doing your job. Sorry, I'm going to just say it that way. Embed in trauma-informed care, especially for women, Indigenous folks, queer, youth, migrant, and of course racialized folks as well. Address housing. Housing should be on your list of your assessment. It saves lives and it reduces distress. There's an abundance of evidence, even though our governments keep trying to hide it or pretend that's not the way. So, thinking about how you can prescribe, social prescribing, the idea that you're prescribing clinic to community pathways. That's one of those ways of saying, yep, community practice is critical. So with that, I will give you a lovely image of a stupid Canadian wolf bird. I will leave it at that because I know time is tight.
Thank you so much to everybody for some, really fantastic and insightful presentations. I know we're really sort of coming to the top of the hour. And in some ways, I feel like we've just started the conversation. We could definitely go, take another hour or two to really delve into it. But I want to thank everyone for coming out. I want to thank the panelists for really sharing their insights. You can see mental health is something that impacts every stage, even pre-diagnosis. And clearly, it needs a concerted, continual attention and efforts. I want to thank Merck and CAHR for the opportunity to have this symposium, and hopefully this is just the first in maybe an ongoing series on mental health. So thanks very much.